Cersei, do you mind making me co-host?
Of course, of course. That was like my next thing I was doing. I'm watching it. The little thing confirmed that we're streaming. If I also have to turn it off because there's a delay. All right. I'm going to, Catherine, I'm about to hit start on the webinar. Excuse me. And then we'll be live. Okay.
And let me know when to begin.
Okay. So 3, 2, we are live.
All right. Hello, everyone, and welcome. My name is Catherine Tasis, and I'm the director of the BCPH Research Scholars Program and co-editor-in-chief of the Boston Congress of Public Health Review. And we're so glad that you could all make it today, especially for our American friends joining us this Thanksgiving weekend. So on this special weekend, I'm especially grateful for the chance to come together and for what we're going to be sharing and learning today. So before we begin, I'll pass it off to my colleagues, Cersei and Candace, to just take a moment to introduce themselves.
Well, I guess I'll go ahead and go first. So Dr. Carpenter, very excited to be here for the inaugural cohort graduates of Research Scholars Program. I'm one of the co-CEOs of BCPH, Chief Strategy Officer, and then one of the co-editors in chief of the BCPH Review. Thank you all for coming.
Hello, everyone. Again, just to echo what my colleague just said, very excited to be having this session today. Thank you to Mia and Nicole for sharing your research and for Dr. Kruti for being such an amazing mentor. This is an important program and we are excited to share it with you. My name is Dr. Cersei Lecomte. I'm co-CEO of the Boston Congress of Public Health and co-editor-in-chief of the BCPH Review. And I'd like to hand it back to Catherine.
All right, thank you. So if we can share our slides for today, I might actually begin by shifting things over to Candace, if you don't mind, one of our co-CEOs, to just explain a little bit about our organization.
Absolutely. I'll pause and I'll wait for the slides to come up. Wonderful. I'm able to see. Do you mind progressing one slide?
Thank you.
All right. So some of you may know, I see some people in the audience that I recognize as well, but BCPH, we are a independent private nonprofit democratizing public health through the lens of social justice. And if we move forward, I can say a little bit about RSP. And so the Research Scholars Program was something that had been incubating in our minds for several months, if not maybe over a year from this moment. So we're so excited to actually see the culmination of everything coming together. So ultimately, the RSP is a concentrated, immersive 12-week program where we pair very ambitious, motivated, talented researchers such as Mia Moore and Nicole Giorgi, with very accomplished mentors such as Dr. Crudy and Dr. Lecomte, and we allow them to be able to put together one or more research manuscripts, as well as posters and then presentations, as you'll see today. And so this is one of our flagship programs to help to dovetail with our mission, that cultivating of the next generation of public health leaders. And both Mia and Nicole represent absolutely the next generation vis-a-vis like the Research Scholars Program. So absolutely helping those scholars develop and if not ignite their research portfolios and obviously catalyze their leadership as well.
Yes, that's right. So this program is really all about personal mentorship and participants gaining those skills and the confidence needed to become part of the community in terms of advocating for social justice and public health practice. But without further ado, it's my pleasure to introduce our inaugural cohort. So on the next slide, we can see our presenters for today. And first, we're having Nicole Gregory, our 2025 student scholar from the University of Southern California. And joining her is Dr. Cersei Gray LeConte, our 2025 RSP faculty mentor and co-CEO of BCPH. So I'll let you both take a moment to share a little bit more about yourselves.
So I can go first. My name is Nicole, and I've been an RSP student scholar, and I'm an undergrad student at the University of Southern California, and I've had an amazing time in this research program. I've learned so much, and I've been able to work with my mentor, Dr. Lecomte, really closely, and we've been able to put out a paper and a research letter, which has been really rewarding and something that's, interconnected with my interest in health equity and health policy. And so it's been a really amazing experience. And with that, I'd love to hand it off to Dr. Lecomte.
Thank you so much. I want to say first, it was an absolute pleasure working with Nicole. The honor of doing the Research Scholars Program, if you're on the call today and thinking about being a mentor, is having the opportunity to work with someone who's new to the field but has such enthusiasm for the field and comes with so much talent and readiness and preparation to like really apply their skills and build their skills to benefit the field of public health. So I've already, as I explained before, I'm co-CEO of BCPH and co-editor-in-chief of our journal, but I'm also a qualitative and quantitative researcher, and I have a background in social epidemiology. So working with Nicole was a great partnership because we had shared interests in improving the health outcomes of populations that are more likely to be engaging in the use of emergency departments as primary care. So, and how can we identify the issues that might be driving that or not driving that, and how we might improve things in the future. So it was a really great partnership. It was a form of research that I normally would not have been able to pursue without this program, and to pursue it in partnership with someone who was so enthusiastic and such a great writing partner and everything was a true pleasure. So with that, I'd like to hand it back so we can have the next team talk.
Thank you so much to both of you. So our next team includes Mia Moore, our 2025 student scholar from the University of Southern California. And joining her is Dr. Kruti Chaliwala, her 2025 Research Scholars Program faculty mentor from Boise State University. So Mia and Dr. Chaliwala, thank you both for being here with us. And if you'd like, please take a moment to introduce yourselves as well.
Of course. Hi, everyone. My name is Mia Moore, and as Catherine discussed a little bit, I am also a student from the University of Southern California. I'm a fourth-year undergraduate studying public health, and I also have a minor in law and social justice. Additionally, I have just started a master's in public health, so I'm very passionate about understanding health data systems and health equity, especially for unique populations, which I'll be able to talk about in my research today. But I've been a research scholar for about 4 months now, and it's just been an amazing opportunity to just really conduct some amazing research and kind of bring to light a population that really hits close to home for me. And so I had the privilege of working with my mentor, Dr. Kruti, who has just been so supportive, and I'm just so appreciative of her and all that she has helped us or helped me with throughout the program. And I've been able to just learn some really, really cool research methods, both qualitatively and quantitatively. And this wouldn't have been possible without Dr. Kruti as well as the BCPH leadership team. So I'm very, very thankful for this time and that I get to present my research today. And I can now pass it off to my mentor, Dr. Kruti.
Hello, everyone. I'm Dr. Kruti Chaliawala. I'm an assistant professor at Boise State University. I second what Dr. Lecomte said about this program, that this is something that you couldn't do in your regular research. So it is a good program even for mentors to learn new subjects that are out there, as well as what is the next generation really passionate about, as well as giving your input, giving your expertise, and helping the next generation form that passion and encouragement to the health equity. My research usually focuses on minority health, which went really well with Mia's interest in minority health, and it was in a sense match made in heaven that I wouldn't have found otherwise. So I was really excited in this program, as well as I'm very proud of what Mia has achieved in a short period of time, because this program is it starts and it ends at the same time. That's what I feel. It started like a few days ago and now it's done. But it was not days, it was months, but it feels like that. Because apart from everything that we are doing in our lives, we are also doing this research. So it just shows our passion for research, as well as it shows the dedication of Mia when coming to this work. So thank you so much for this opportunity. And this is really a great program.
All right, thank you so much to both of you, and I'm sure we're very excited to hear from our scholars and mentors. So as a quick introduction to the presentations, Nicole and Dr. Lecomte will be presenting first and starting us off on the topic of emergency department use that's avoidable and possible innovative solutions in New York, and they'll be presenting on 2 articles. Following that, we'll have Mia and Dr. Shalawala present on cardiovascular health outcomes among Afro-Caribbean immigrants in the United States. So we're very excited to hear your insights, and I'll pass it off to Nicole and Dr. LeConte.
Okay, so thank you, Catherine, for introducing our research project. My name is Nicole, as I said before, and my mentor that I've been working on this project really close is Dr. Lecomte. And what we studied was the association of insurance type with the use of emergency care in New York. So a little bit of background on our topic is looking at the avoidable ED visit rate in New York. So it's about a 40% rate is what we found, which is already a very high number, but we found that this was disproportionately higher in New York City as well. And this contributes to several different issues. It contributes to the already small and overburdened emergency healthcare workforce, and it also contributes to worsening patient well-being and outcome, and it brings into the idea of a standard of care. So if patients are resorting to using the emergency department, it brings into question their standard of care and their continuity of care. And so moving on to our methods, what we did was we looked at the health data in New York, specifically from the statewide planning and research cooperative system. And what it was is it was a population of about 430,000 patients, and we looked at specifically hospital inpatient discharges. And so some of our key analytical variables was the primary predictor, which is payment type. So looking at whether a patient was privately insured, publicly insured, or uninsured. We had our outcome, which was admissions type of avoidable versus unavoidable, and then some other covariates. So our demographics were included in this Sparks data set, as well as admissions data. And then finally, for our methods, we used SPSS version 31 to calculate some of the following tests in order to get our results. So we performed bivariate unadjusted tests between our insurance type and our covariates. We performed cross tabulations, chi-square tests, Kramer's V, and we also performed multinomial logistic regression. So we looked at the adjusted outputs ratio and confidence interval for each insurance type. So we did a lot of these statistical tests in order to get our results, which I will show on the next slide. So first is a table, which is just a summary of our analytics sample to display. This was the makeup and demographic makeup of our data set. So we put it into a table, and we have the percentage of gender, ethnicity, race, age, avoidable ED visits, so whether the visit was minor or non-minor. And our data was pretty evenly dispersed. We found about 50 and 50% were male, 50% were female, a little bit more than 50% was female. And moving on to our insurance type, we also made a plot to distribute how insurance type made up our sample. So we had about 80% were publicly insured, 18% were privately insured, and then about a little under 3% were uninsured patients. And so on to our results, we found, interestingly, that publicly insured patients were 14% less likely to have avoidable emergency department use. We found that publicly insured holders were more likely to be New York residents, they're more likely to be Hispanic, and they're more likely to be Black as well. And we found that uninsured patients were more likely to be younger, non-white, and clinically at higher risk. And so during our statistical test, we found that age group, ethnicity, and race exerted the largest effects on insurance classification, which is a really interesting result. And then some more results. This was a forest plot of our adjusted odds ratio. And what it does is it compares public versus private insurance across the following domains on the left. And they reiterate the results that we talked about in the previous slides, how publicly insured patients were more likely to be Black, more likely to be Hispanic, and more likely to be New York City residents as opposed to privately insured patients who are more likely to be older, they're more likely to be white, and somewhat more likely to be male. Okay, and then moving on to our discussion portion of our paper, we looked at the association between public and private insurance and avoidable ED visits. So a little bit of background is that the Affordable Care Act increased private insurance coverage as well as emergency department usage. So publicly insured, and this goes to demonstrate that there are publicly insured and uninsured coverage gaps and challenges that still persist. So issues such as social determinants, so lack of transportation to healthcare checkups, to places that they need to be are contributors of the fact that of some of the challenges and gaps that exist. There are also issues such as publicly insured or uninsured patients may face greater concentration of emergency events, such as violence, accidents, or just a delayed and deferred care that leads to increased emergency events. And then we also found that sometimes it's strategic use of the ED due to limited supply of primary care providers and appointments. So in areas where there are very few primary care checkups available, primary care doctors available, or even primary care locations that take Medicare or uninsured patients, that contributes to the idea of emergency department use that are actually emergent by these publicly insured and uninsured patients. And so what we said in our paper was that this gives us the opportunity to examine the emergency department uptake in intersections of multiple different demographics, so race, sexual orientation, clinical concern, documentation status, and we talk about all of this in our paper. And so just a little bit of a conclusion that we talked about in our paper is improving emergency department efficiency would help mitigate the impact on the overburdened workforce and help improve overall patient well-being. So if we can help patients, we can reduce the amount of deferred care, we can reduce the amount of emergent and non-emergent ED visit, that will overall help the overburdened workforce, physician burnout, as well as improving their patient well-being, their standard of care. And we talk about how additional supports are necessary to creating the standard of care. And it's not just Medicaid expansion. So as I mentioned in my last slide, there are all these factors of social determinants, non-emergent events, and the lack of healthcare, primary healthcare availability and checkups that are also important to establishing this continuity of care. We also talk about implications for future health policy around improving a standard of care and reducing emergency department reliance. And then finally, we discuss about how future research should examine medical conditions contributing to the emergency department use overall, and how this contributes by different demographics of public versus private versus uninsured, the risk of mortality, race, and age. And finally, this moves on to the research letter that me and Dr. Lecomte have been working on, is the implications for the future. And what we specifically focus on, which is really interesting, are artificial intelligence innovations that can help mitigate avoidable emergency department use. So with artificial intelligence becoming more and more widespread and more integrated by different companies, different businesses, different hospitals, we thought it was an interesting tool to look at and study and figure out how this will relate to emergency department use. So we looked at how predictive AI and machine learning models can be used for risk identification, so identifying high-risk patients, and helping with navigation and other wraparound services. We looked at how operational AI can be used to manage overcrowding. So different tools that are able to identify bottlenecks and reduce ED congestion, to optimize patient flow, to help note-taking when healthcare professionals are meeting with their patients. And then finally, we looked at equity-focused implementation agenda. So the idea of integrating AI tools such as chatbots, wearables, and decision support systems to help improve access, reduce avoidable ED visits, and overall help the overburdened workforce and providers. And so that leads us into the Q&A portion of our presentation, and thank you for listening.
Nicole, that was really nice. And I just wanted to tag on that you had some surprising findings, because when we first started working on this project together, you had thought, and I had thought, that those who were being publicly insured would have more emergency department use. And that's what's found in a lot of the literature. But here you were able to find something that occupied a slightly different and more nuanced space in the literature and aligned with some of the research being done now, which is showing, as you discussed, some folks who were doing more strategic use of the emergency department. It's much more strategic than folks had initially thought, where those who do have private insurance may be living in areas where they don't have access to they have private insurance, but they don't have access to those who can take it. So they have to use the emergency department strategically. So,
yes,
yeah.
It was really surprising when we did it. But upon further analysis and like looking at the research, it was really interesting find, and I'm glad that I was able to do it with you, Dr. Lecomte.
Oh my goodness, Nicole. It was a pleasure working with you. Thank you for trusting us with this process and your research ideas. And we've already talked about opportunities to expand upon these inquiries. So, yes. Catherine, I didn't know if you wanted to do question and answers now, or if you wanted to wait till the end after our colleagues go.
Yeah, of course. Well, thank you so much, Nicole, for your very informative and detailed presentation. We'd be happy to take any questions if there are now while we switch over to the second presentation. But again, congratulations on a wonderful presentation to the group.
Okay. So I will take back over for a moment.
All right, thank you. So we can begin to transition to Mia and Dr. Chalawalla's piece, who will be discussing cardiovascular health outcomes among Afro-Caribbean immigrants in the United States. And Mia, I'll let you share your slides and take it away.
I first just want to echo what an amazing job you did, Nicole. That was a really interesting research that you conducted, especially looking in the health policy space, which is one of my interests and maybe even a little bit of something that kind of goes into a little bit of my research as well. And so I think it's just really cool how we both found similar findings, and thank you for sharing just such an amazing research and even linking it to future innovations in AI. So just wanted to give you your flowers there, and I can begin my research. So hello, everyone. My name is Mia Moore, and today I'll be presenting my systematic literature review titled Cardiovascular Health Trajectories of Afro-Caribbean Immigrants in the United States. This project was completed under the Boston Congress of Public Health Research Scholars Program with mentorship from Dr. Kruti Chaliawala. To begin with some background, cardiovascular disease remains the leading cause of death in the US, and Black populations, including immigrants, experience a disproportionate burden. At the same time, however, Afro-Caribbeans are one of the fastest growing Black immigrant groups, making up over 50% of the US Black immigrant population. But despite this, Afro-Caribbeans remain largely underexamined compared to African Americans and African immigrants, and their unique cardiovascular profiles and the social determinants behind them are often overlooked. And a key point in the literature is that cardiometabolic risk, so things like hypertension, diabetes, and obesity, are all primarily driven by social, environmental, and structural factors rather than genetics. Yet there are gaps in current literature because most studies actually aggregate Afro-Caribbeans with African Americans, meaning that they are masked within subgroup specific patterns that aren't shown in literature because of being aggregated with other populations that don't exactly match the health patterns that are unique to Afro-Caribbeans. And so this lack of disaggregation delays targeted interventions, and also it limits our ability to understand the true cardiovascular risk among Caribbean origin Black immigrants. Just to go into the significance, this research matters for several reasons. First, the literature consistently showed a healthy immigrant effect, where first-generation immigrants arrive with healthier profiles due to traditional diets, more active lifestyles, and strong community ties. But over time and across generations, this advantage starts to diminish, which widens equity gaps, and also it highlights the impact of US social and structural conditions. So understanding cardiovascular health trajectories is essential for building equitable public health systems that design preventive strategies and also develop culturally responsive policy reforms that reflect the experiences of Afro-Caribbean communities. And this leads into my research question, where my literature review asks, how do the length of US residence, generational status, and structural determinants shape cardiovascular health outcomes among Afro-Caribbean immigrants? So to answer this question, I conducted something called a systematic literature review using PRISMA guidelines and multi-database searches, where searches were run through multiple databases such as PubMed, JSTOR, Springer Leak, ProQuest, and more. So after applying a specific inclusion criteria, I found 6 studies published between 2019 and 2025, which met all my requirements. And studies from the past 6 years were selected in order to capture the most current and methodologically rigorous and disaggregated research on Afro-Caribbean cardiovascular health. And these studies also examined CV risk through acculturation, length of residence, and structural factors among Afro-Caribbean populations. And going into my results, it's very interesting how I found a wealth of results from only 6 studies. And I think this just shows a lot in terms of future implications and what this could mean for this specific population. So the first major theme in my results was acculturation, which is defined as the cultural modification of an individual group or people by adapting to another culture, which operated through 3 main pathways in my specific research: diet, physical activity, and environment. So starting with dietary acculturation, I wanted to show this slide because after migration, Afro-Caribbeans go through something that's very unique and a little bit troubling. One, they shift from traditional diets that are rich in fresh produce, legumes, and fish to more processed and high sodium US foods. And research shows that Caribbean dense neighborhoods, specifically New York, such as Flatbush and South Ozone Park, have fewer BMI healthy food outlets. And this highlights how neighborhood context shapes the diet-related risks and contributes to rising obesity and hypertension over time for this population. Similarly, physical activity begins to decline with prolonged exposure to US environments, especially in neighborhoods with low walkability, transportation barriers, or limited green space. And these environmental and structural constraints significantly shape the cardiovascular health trajectories of Afro-Caribbean immigrants. Additionally, I found results in length of residence and generational status. So length of residence emerged as a very powerful predictor of cardiovascular decline. Specifically for a second generation, my literature review found that living in the US for more than 10 years is associated with significantly worse cardiovascular outcomes among Afro-Caribbean immigrants. And we also see a clear second generation decline in my image on the left, where US-born Afro-Caribbeans display higher CVD risk than their parents, and in some cases, even higher than African Americans. And these reflect the generational differences in coping, where first-generation Caribbean immigrants rely on strong community ties, faith-based networks, and traditional values that focus on cultural retention. In contrast, though, second-generation Afro-Caribbeans adopt US behavioral norms such as hypervigilance, isolation, and withdrawal. Additionally, I found research results in structural racism and discrimination. So structural racism was a consistent driver of cardiovascular health outcomes across the literature review as well, where second-generation Afro-Caribbeans report the highest levels of discrimination, which contribute to their cardiovascular decline. Additionally, healthcare bias also exists. Within the literature review specifically, it was found that highly educated Afro-Caribbean women face maternal health inequities, including disproportionate cardiovascular complications. And this shows how gender and intersectionality both play a critical role in understanding cardiovascular outcomes among Afro-Caribbean immigrants. And this is because women face unique layered vulnerabilities. So there's various intersectionalities that exist and that I found within the literature review. And then lastly, chronic stress pathways. So chronic exposure to racism is linked to hypertension, left ventricular hypertrophy, and systemic inflammation. And these all reinforce that cardiovascular health is deeply shaped by structural and not individual factors. So moving on into my discussion, overall, the literature review clearly supports a deterioration in cardiovascular health across time and across generations for this specific population. And these patterns are shaped by several intersectional factors. The literature review points to factors like nativity, acculturation, length of residence, the overall built environment, discrimination, and socioeconomic conditions, which all must be centered in our understanding of cardiovascular disparities for Afro-Caribbean immigrants. Several implications also emerged from this review. So first, cardiovascular programs must be culturally tailored to incorporate Caribbean diets, their specific community engagement, and also family structures. Second, prevention should begin early in the migration process before those protective behaviors start to erode. And third, the structural reform, so not just individual behavior change, is necessary. And this includes addressing racism, improving access to culturally competent care, and also investing in safe, walkable environments. And finally, investing in disaggregated data is very critical. Must not be statistically blended into broad racial categories if we want accurate and equitable public health research. In conclusion, the health advantage is temporary, and because of acculturation over time through shifts in diet, physical activity, and environment, these all contribute to worsening cardiovascular outcomes. And importantly, having an intersectional lens is essential because ethnicity and immigration, gender, class, and environment, all of these converge to shape the cardiovascular risk among Afro-Caribbean communities. Lastly, equity begins with visibility. So we must invest in data, in systems, and policies that accurately reflect the experiences of Afro-Caribbean immigrants so that we can build on interventions that truly meet their needs. I have attached this slide as a reference. If you scan the QR code, you can see the list of references that I address in my literature review. And finally, I just want to give a huge thank you to everyone here that is listening in the audience. And I'd like to just thank the BCPH leadership team, Dr. Carpenter, Dr. LeCompte, and Catherine for the opportunity to conduct this research. And just a very, very huge thank you to my mentor, Kruti, for all of her support throughout the program. And I'm happy to answer any questions at this time. Thank you.
Thank you so much, Mia. That was an excellent presentation and quite interesting as well. So just looking at the chat, I see we do have a question for Nicole, but perhaps I could start off the discussion with a question for you, Mia. And I'm curious, in your research, did you come across any ways to maintain this health advantage in the US environment? And perhaps is it even possible? I know you spoke about prevention, but is it possible to keep this trend continuing before we need to get to those preventative steps?
Thank you for your question, Catherine. That's really interesting. And yes, I actually found ways that we can maintain this. One specifically I learned from doing literature review is something called ethnic enclaves. So specifically when immigrants from the Caribbean are moving to areas where they are ethnically represented, then they feel more likely to have those protective factors such as their diet remain the same, as well as those green spaces and the whole environment, as well as just having family community ties are really important. So I found that one way is through having ethnic enclave environments. Another way is just having certain culturally tailored programs that play a role into how Afro-Caribbeans can best transition into the United States by protecting their overall language, as well as just their communities, and being able to support them in different ways, socially, relationally, in different ways. And so just preparing these programs that are specific to Afro-Caribbeans is just one way that we can continue to protect these populations.
Thank you, Mia. Perhaps I'll read one of the questions in the chat for you, and then we'll move to Nicole as well. I see,
Okay. Just really quickly, there was someone in the audience who had a question.
of course.
Catherine, I didn't know if you could see their hand.
No,
Do we want to invite that person to ask their question verbally?
definitely, of course.
Okay. I hope it's okay. I hope I wasn't being rude by
Oh, no, of course.
interrupting you.
Uh,
So,
sorry about that, but if you do have
no.
please speak up.
So, Pamela, I've unmuted you, Pamela, if you would like to ask your question.
Yes, wonderful, wonderful presentation. Thank you so much. As a speech language pathologist and working with the Afro-Caribbean population, I do have the opportunity to talk with families, and I hear different nuances regarding medical mistrust as it pertains to food security as well as nutritional differences in the United States versus in the Caribbean. Did you find any of that information in the in your literature review and in your research?
Yeah, specifically with dietary acculturation, it's clearly evident. I think in all of my studies, they discuss how specifically, diet, especially with the certain food groups that Afro-Caribbean communities rely on, and specifically in Afro-Caribbean countries, they have access to farmers markets and ethnic grocery stores that specifically focus on providing them with the diet that they are so used to. But then coming to the US, one specific example that I found was in New York specifically, right, where they have neighborhoods that don't have healthy BMI outlets or farmers markets or grocery stores that can particularly pertain to this group. That affects their overall kind of that affects their overall health. And because of that, that's what leads to hypertension, and that's what leads to systemic inflammation in their overall blood systems. And so that evidence was clear. And I think one way that we can move forward and kind of be brought out of that and support this population is by making sure that the locations that Afro-Caribbean immigrants are moving to have access to healthy BMI outlets and grocery stores as well as farmers markets, and just being more aware of that population. And then you mentioned medical mistrust, which is very evident because even as an Afro-Caribbean myself, I've seen my grandparents kind of struggle with the language barrier and not having trust in the providers that they speak to. And so I think that'll really take a lot more, just this research that I've conducted, but it'll take kind of a long-standing study where, like I mentioned, needing to disaggregate the data, understanding the various language dialects that Afro-Caribbeans have, and then finding community health workers that support that language and are fluent in that language to go in and kind of be that middleman for these populations.
I agree. I also think like perhaps, the medical mistrust index, devising or formulating one specifically that captures and at least opens that communication and that conversation with Afro-Caribbean families so that they do have, a way or a conversation starter to even communicate these areas of of struggling, of the divide going between the provider and our families.
100%. And even just outside of this research with BCPH, I hope to continue doing more research and looking into more studies and what can be done specifically in policy reform and also in the healthcare system as well. So thank you so much, Pamela. This really does hit home for me. So I appreciate that there are other people out there that find this just something that needs to be talked about more.
Yes, thank you so much for your question, Pamela. Circe, would you mind, is there any other hands up that might be in the audience?
I don't see any hands up in the audience at this time. There's a few questions in the chat, as you were mentioning before.
All right, so maybe to switch things up, I'll jump to a question for Nicole. And one of the questions in the chat is, why do you think the political trend or argument to deprofessionalize public health, OTPT, and nursing degrees will do to the workforce and impact the trajectory of your findings?
Yeah, thank you. I think that's a wonderful question, and it's really, really interesting to think about. It is a complicated and posed argument because there does exist a physician shortage. There is a shortage of a lot of healthcare professionals, but I believe that it has a significant consequence for both the healthcare workforce and the findings of our research. I think that professional preparation in these fields help ensure that these professionals are able to safely navigate complex patient needs, and especially when dealing with publicly and uninsured patients. Sometimes the patient need is a lot more complex. And I think that professionalization will lead to increased burdens on maybe highly trained clinicians and higher rates of clinical errors due to gaps in training. And I think that it will worsen avoidable ED visits due to less trained staff struggling to manage chronic conditions or recognize red flags and provide a consistent and preventative care. So I think the answer to this question is that it complicates health outcomes further. And we see this like we see differences in the utilization or care quality that will start to be reflected with these patients. So I think it's a complex question and it's a really interesting question. But I do think that it will deepen health inequities, and I do think it will worsen avoidable ED visits.
Thank you, Nicole.
Mind if I hop in, Catherine? Yeah, so the reason I asked that, Nicole, just because, especially for the audience, if you guys haven't been following, Trump's proposal to basically take nursing, people in occupational physical therapy, public health, which many of us on the call have degrees in as well, to deprofessionalize all of those. And so I immediately saw a connection with Nichols and Dr. Lecomp's research, and it's echoed in many other research as well, not just yours, but wanted to just kind of bring that to the forefront, and thinking of one, that we need to advocate strongly so that this doesn't happen, because I agree with you, Nicole, that the results can be quite disastrous, not just in the ED, but across the entire health landscape. So anyway, wanted to just jump in there and mention that.
Thank you for the question. It's really interesting.
Yeah, and Pamela has added speech pathology and audiology as perhaps areas that may be impacted as well.
And I really think it also speaks to like the power of this program in allowing, new and emerging thought leaders like Mia and Nicole to address issues that have such resonance with the public health arena, not just in theory, but in potential action as well. So.
All right, maybe we can switch gears a bit and ask another question for Mia. I see in the chat here, there's a question about why do you think there's less focus on public health research on Afro-Caribbeans?
Yes, great question. Was that from Dr. Carpenter?
Yes.
Awesome. Thank you for asking. And this is really interesting because it did come up in the literature review and it made me kind of think about, yeah, why is this specific unique population not addressed? And one reason is because of disaggregated data. And so that means that ultimately they're being kind of embedded within the overall African population. So that also includes like African Americans and African immigrants, as well as just everyone within the African diaspora, that it doesn't specifically disaggregate, let's say, Haitian populations or Jamaican populations, or specifically those from certain Afro-Caribbean communities that have unique public health concerns. And I think one reason for that is just because there's just not enough research being done for this specific population, especially for when they kind of come to the US. They go straight to, joining the workforce and ultimately kind of remaining kind of hidden within ethnic enclaves. And so I think that is one reason why this population isn't discussed as much in literature and in research. And also, I think it's important that we consider this population because, as I mentioned earlier, they do make up over 50% of the Black population, and that says a lot. And so it means that we specifically need to look into what are the health implications for Afro-Caribbean immigrants, specifically overall in immigrant health. So that is my answer. Thank you.
Yeah, no, I love that you mentioned that, Mia. And if I can tag on, because I get so excited
Yeah,
with conversation
definitely.
as well. And I think this is something you probably even argued when you were doing public health, Cersei, at Chan, the whole issue of like, do we excessively aggregate versus do we disaggregate and why? Right. So if we aggregate, all Black and African American, it may be more efficient and statistically
Mhm.
easier. But at the same time, there can be a number of different detrimental downstream effects, from that, right? Of not looking at those individual groups. But it's staggering, right? 50% of the Black population is Afro-Caribbean. That is wild. And I think that is huge, right? Not just to
Mhm.
what I think Pamela said, right? The assumption that, all of Black is monolithic, but the same thing happens for all different groups, right? That all Asian groups, all Southeast Asian groups, all Latinx group, and we all know, well, those of us on the call understand that is not true, and incredibly detrimental. And I could get into, all sorts of like white hegemony and how ultimately that kind of perspective and not having enough researchers such as yourself, right, Mia and Nicole, having that proximity and that lived experience to certain types of groups, to me, makes you even more qualified and urgently needed to be able to do this kind of research. Because if we just have the same types of individuals doing it, we're not going to be able to get this kind of data. People aren't going to care. It's going to be a blind spot that they can't kind of work their way out of.
Exactly. Yeah. Thank you for that question.
All right, thank you for that discussion. Cersei, I'm just going to pause. Are there any other hands that may be up in the audience? Otherwise, I'll read.
I'm just checking here. I don't see any questions right now. Any hands? No.
Sounds good. All right, so another question for Nicole, and this question is from your mentor. The question asks, do you think the trends we observed here in our research will be the same in states that have not participated in the ACA Medicaid expansion? Thinking of the difference between Medicaid expansion in a state like New York versus Florida.
Thank you, Dr. Lecomte. It's a really interesting question, um, and it's really relevant. And I think we briefly talk about it in our paper. But to answer your question, I don't think the trends we observe would look exactly the same in other states that did not participate in the Medicaid expansion. And I say this because in a Medicaid expansion state like New York, a lot of low-income adults still have a form of coverage. And so when we found a surprising result that publicly insured holders were 14% less likely to use the emergency department for an avoidable reason. And so we found that maybe it stems from different barriers. So different access barriers, different social determinants, an increase of emergent events that led to our results. And so in Medicaid expansion states, I think the avoidable ED trend stems from access barriers, appointments shortages, transportation, etc. But in non-expansion states like Florida, I think I think a lot of the larger gap is due to insurance gaps. So a lot of adults fall into not getting coverage, which forces them to rely on the ED for basic care, which also delays treatment and until conditions become emergent. So I think there will be some similarities, but there will also be a lot of differences due to this fundamental insurance coverage difference. And so yeah, that's how I would that's my answer to your question.
Yes, no, that's a very, very thoughtful answer and one grounded in our analyses. So thank you for that.
Thank you.
Yes, thank you. I think we've had an excellent discussion so far. I just want to pause briefly in case there are any last few questions. But if they're not, be glad to move to the next portion of the event, which is the awards ceremony. I'm sure we're all excited for that. So I'll just pause a moment. Let me know if there are any questions. We'd be happy to hear them. Okay, I'm seeing a lot of little applause icons. So again, excellent to both groups. Very glad to hear about your research and your presentations, and it looks like the audience appreciates it as well. Circe, if you don't mind, switching back to our other set of slides, I believe we can begin with the presentations of awards.
Yes, give me just one moment. The slides are coming up. Are you able to see them?
Not quite yet, but I might have a bit of a slow connection.
Yeah, we don't quite see your.
Okay, hold on. Let's try it again.
Yeah, you have a couple different things on your computer that we see.
Oh, that's very strange. I don't know why it's doing that. So you're seeing, here we go. Are you seeing it now?
No.
Ah, there we go. Okay.
Are you able to see the slides now?
Yes.
Great. Okay. I don't know why there was a delay, but here we go.
All right. So if we could skip to the section of the presentation. I'm delighted to begin the award ceremony to really recognize both the outstanding mentors and student scholars in the program. So it's my pleasure to confer the Certificate of Achievement for Student Scholar to Nicole Georgie. Nicole has shown remarkable effort and dedication throughout our 12-week session in completing 2 manuscript submissions, as well as her academic poster. This has been wonderful work, Nicole, and we wish you congratulations on your success.
Thank you so much. It's been amazing being part of this research program, and I've met so many wonderful mentors. So it's been amazing. Thank you.
Next, we are pleased to confer the Certificate of Achievement to student scholar Mia Moore. It's been wonderful hearing about Mia's research and really seeing her hard work during the program. So congratulations, Mia. You've shown wonderful dedication and real critical thinking during your time with us.
Thank you so much, especially to the leadership team and Dr. Kruti. I've learned so much in just such a short amount of time. As Kruti said, it really did feel like a few days, but all of that to say, I wouldn't have been able to be as confident as I am now in my public speaking skills and my research abilities if it wasn't for this program. So I'm deeply grateful for everyone and just all of the support you all provided me. Thank you.
Oh, thank you. That's nice to hear. And I'm seeing congratulations in the audience as well. So, of course, this is a very well-earned achievement to you both, and we're incredibly proud of what you've accomplished. I want to switch gears a little bit and take a moment to thank our faculty mentors as well for their leadership, for their guidance, and of course, for their dedication. The support throughout this program from you both has been truly invaluable to the students' growth and success. So it's my pleasure to confer the Certificate of Recognition to Dr. Kruti Chaliwala. And Dr. Chaliwala, your mentorship over the last 12 weeks has been wonderful. The guidance, the encouragement, and the commitment have really made a lasting impact on your student scholar, Mia, as you've heard. And we are truly grateful for your dedication.
Thank you so much. I really appreciate it. I know BCPH is a huge program, and getting that validation as a emerging scholar myself is a huge thing. I have done some research in past, but this is something that just gives you a thumbs up that what you are doing is great and it is being recognized. So thank you so much. And Mia, thank you for being my mentee and being on your toes and listening to all the things that I had to say. Thank you so much.
All right, thank you. It's also a pleasure to confer the Certificate of Recognition to Dr. Lecomte for her mentorship to Nicole during the program. Dr. Lecomte, you've dedicated your time, your knowledge to help really create an excellent learning experience. And of course, we are also grateful for your support.
Well, thank you. And I think I've said it before, it was such a wonderful experience to be able to work with a mentee who shared my interests, and we were able to produce, I think, a very interesting piece of scholarship to add to the literature. And I must say that moving forward, other mentees will have a lot to live up to because Nicole has created some very big shoes to fill. And it sounds like Mia has as well. So thank you very much for your dedication. It was a whirlwind of an experience, but it just shows like what you can get done when you are dedicated. So thank you.
So a big congratulations to both the student scholars and the faculty mentors. Your dedication is truly what makes the program what it is, and it's really been wonderful seeing all your research journeys develop. I see lots more congratulations in the chat to both the mentors and the students. So really appreciate the audience attendance today and of course all the amazing presentations. But before we transition to our information session in a little bit, I wanted to pause and see if Candace or Circe, if you'd like to say a few words to wrap us up.
Yeah, I mean, I think it's been said, but once again, big round of applause to our scholars, to the mentors, and to all of those of you in the audience. Spread the word. We want to make this an even larger program. Mia and Nicole, and obviously Dr. Kruti were very courageous in taking that first step. And anytime we do an inaugural cohort with BCPH, we never know how things are going to turn out. So we appreciate people who are willing to break the ice and work with us and to be able to establish a program. But absolutely, we enjoy seeing other people who have the same ambition to be able to increase the knowledge within the public health sector, especially with the political climate that we find ourselves in. So thank you again, Catherine, great leadership, and to all of you for being our first.
Oh, thank you so much.
Wonderful.
Yeah. So I'd like to invite everyone who's interested to please hang back and we'll begin our information session for cohort 2. But to those leaving, thank you so much for joining us today. We really appreciate your time.
Bye-bye. Thank you.
Thank you, Mia.
Thank you. What a pleasure.
All right, so it looks like we can begin our short information session. As I mentioned, this will be primarily geared towards cohort 2, which we're going to be beginning in the winter term. But as a quick recap, the BCPH Scholars Program is a 3-month learning journey where participants work closely with public health researchers and a mentor to complete one publication, one academic poster, and as you've seen, one live webinar presentation. So the program is really designed to give participants this hands-on and supportive experience. And in terms of program activities, it begins with an orientation and an onboarding. And that would be followed by weekly mentoring opportunities as students develop their research projects over the course of the 3 months. The BCPH RSP leadership team also schedules regular check-ins and feedback sessions with both students and mentors at intervals. And students will have access to skills building workshops and resources from BCPH Academy, which covers everything from research methods to writing, presentation, peer review. It's a variety of courses that can help build skills. In terms of faculty mentor benefits, you will have the benefit of co-authoring publications and posters with free publication in BCPHR after peer review acceptance. You'll also be recognized across program materials, join special events as we've attended today, and perhaps most importantly, also have the chance to guide and work alongside motivated students like Mia and Nicole, really helping to shape the future of health equity research. To touch on the benefits of students as student scholars, As we've reiterated, you'll gain hands-on experience, but really get that opportunity to be a first author on the academic manuscript and poster, which is unique and difficult for students at this early stage in their career to really have a mentorship guided journey that helps them learn and grow and expand their knowledge. So from experienced faculty. So it will really build skills that may advance your career in public health. I also wanted to take a quick moment to mention in terms of the winter cohort that it will kick off in mid-January and we anticipate wrapping up by April. And ultimately, throughout this program, students will build confidence and skills in public speaking, in research design, writing, presenting, while being guided by the mentorship as we've seen here today. And it is really a great opportunity to learn, grow, and showcase your accomplishments. So that's the end of the material review regarding the program. But as we wrap up with that, I wanted to thank everyone for taking the time to be here this weekend and join our learning community. But in terms of questions, if you do have any questions about the program or the application process that you don't get a chance to bring up today, please feel free to reach out to us at communications@bcph.org. And as a reminder, the applications for the winter cohort are going to be due December 8th, 2025. So we hope to see many of you apply. But for now, I'll pause for a moment and invite Candace and Circe to join us as we open the floor to any in-house questions today.
So if folks have any questions, they can put them in the chat. I did see that someone said they love the program and they'd love to help expand it. Charlene, I just didn't, we're wondering, are you talking about as someone who wanted to be a scholar or as someone who wanted to be a faculty member? And if you would be open to it, we could bring you off. I've opened up your microphone if you'd like to share your thoughts.
Awesome. Thank you. I am driving on the road, so bear with me.
Oh my goodness. Oh yes. Thank you for joining us on the road. So
Yes, just listening to it. So I am faculty at Rush University Medical Center, and I was turned on to this program by way of our workforce development, where we are creating our pipeline component, but we're looking for these types of opportunities to share with our high schoolers and our young undergraduates to connect them in this world as it relates directly to research. So I would definitely love to figure out a way to come on to support you guys in any shape, form, or fashion, because public health and research, love it combined together. I'm a public health practitioner and researcher, so I love this.
oh, that is wonderful news. Thank you so much for sharing. And we'll be sure to follow up with you. So.
Yeah, I'll just mention as well. So because this is our first cohort, the way it's designed is for scholar mentors to be paired, and ultimately we can pair scholars and mentors from all over the world. Obviously, the biggest issue potentially could be whether or not scholars and mentors are in significantly different time zones and how they want to work that out. But ultimately, we're open to different kinds of models. So if you happen to have students within, so you said you were at Rush, Charlene, but if you happen to have students and mentor pairs at other institutions and you want to apply together as part of the RSP program, we're open to that as well. However, we can expand the program. I will mention, though, that there is tuition related to this. It was not mentioned, but just to be very transparent, there's tuition on the student side for the RSP program at this time, not for the mentor, but just for the student. And that helps to pay for the publications and all of the other ancillary services that go into this very intensive 12-week program. So just for the sake of that, so open to different types of mentor scholarship pairings. If there are more mentors who want to come on from one institution or one program, one public health school or one medical school, and same thing with scholars as well. So feel free to refer individuals that you have who you feel would be strong candidates for the program. That is correct. At this time, the tuition is $600 for the full fee. And so, given the fact that students don't have a cap on the number of manuscripts that they can do, for us, we typically charge close to $500 for one manuscript. So, for students to be able to do essentially any number of manuscripts that they're capable of doing within
Mhm.
12 weeks, a poster presentation, and this other presentation as well, that is quite a cost savings for $600, and obviously the benefit for the mentor as well, being able to do this level of research and have that publication.
I am curious, on the call, do we have folks interested in being mentors or student scholars? Be interesting to see in the chat. Oh, I see a question here about the application link. We can actually put that in the chat now, but the application link is available on the BCPH website as well, both for student scholars and for faculty mentors.
I'll put that up momentarily.
And we will say as well, so as we mentioned before, when it comes to being a scholar, people are emerging. So typically, obviously, Nicole and Mia are our ideal kinds of individuals. So if you have a profile similar to that, right? So we're open to high school, college. This could also be very important for people just starting out their master's in public health program, or also starting out in medical school. We do understand some people are further along in their career, but this is definitely meant for a younger generation in terms of that full complement. So just so you know, and then in terms of mentors, we are looking for people who do have a good amount of experience being able to publish themselves. So there can be a very strong relationship between the scholar and the mentor. So when you apply, those are the things that we're looking to see.
And yes, thank you, Cersei, for adding the application form link to the chat for those that might be interested.
And I see that Pamela entered into the chat her interest in becoming a scholar, and that she's conducting research next semester on best practices for reentry programming to increase anti-recidivism. So that is very much something that a lot of our folks we've worked with in the past have been interested in with carceral populations. So your research would have a good home. And I'm also going to put in the Q&A that link as well. You can find the link to the form here in the chat, and I will place it elsewhere as well.
But I think we can.
Were there any other? Yeah, I'm sorry, go ahead.
Yeah, just given the time, I think it probably makes sense.
Yeah, I'm just checking. I don't see any last few questions that have popped up in either the chat or the Q&A. So I want to take the time again to thank you all for attending, for showing your interest, and wish you all a great rest of your day.
Wonderful. And thank you to everyone for joining. Thank you, Becky. So with that, I'm going to stop the recording and stop the stream to everyone who's watching on YouTube.